Welcome to today's deep dive. If you are, that curious learner who always wants to know the why behind things, well, you are exactly who we put this together for.
Yeah, absolutely.
Whether you're prepping for a medical board exam or trying to understand the latest research, or even just someone staring at the bottles in your medicine cabinet wondering how they actually function.
Right. It's a very common feeling.
Yeah.
Usually when we talk about a medication, there's this expectation of a straight line, you know?
Right, like engineering.
Exactly. Like you have a headache, you take a pill, the headache goes away. And the doctor just points at the bottle and says, there's your fix. It is deeply comforting to look at pharmacology that way.
We want our drugs to do exactly what it says on the label. Nothing more, nothing less.
But then you step into the actual science.
Hmm.
And suddenly that straight line turns out to be, well, a total maze. The label on the bottle might only tell you a fraction of the story.
Which is wild. And what if I told you that a medication originally invented to act as a weak water pill actually held the secret to slashing heart failure mortality? Yeah.
And what if its most notorious side effect made it a vital staple in modern gender-affirming care? It represents the absolute definition of a medical paradigm shift.
Yeah.
We were looking at a drug class that fundamentally redefined its own purpose over the course of decades.
And that is the mission for us today. We are pulling from a massive stack of pharmacological notes, historical research, and some landmark clinical trials, all centered around a really fascinating class of drugs known as potassium-sparing diuretics.
It's a great topic.
Right. We're going to figure out how they manage to achieve diuresis, meaning fluid removal, without draining the body's potassium. We'll explore why their medical definition has totally shifted over time and how they transformed from being, minor afterthoughts to absolute life-saving necessities.
Exactly.
Okay, let's unpack this. Before we get into the sparing part, I feel like we need to understand the drain.
Yes, the baseline.
Right. Why do normal diuretics make us lose our potassium in the first place?
So, to understand the drain, we really have to look closely at the microscopic plumbing of your kidneys, specifically a tiny structure called the nephron. Your kidneys have millions of these nephrons, and they are essentially long, twisting tubes. Now, most standard diuretics, the heavy hitters you hear about all the time, like loose diuretics or thiazide diuretics, they operate far upstream in this plumbing system.
Right, near the beginning.
Exactly. And their whole job is to stop your body from reabsorbing sodium. By keeping sodium in the urine, it naturally pulls water along with it, flushing that excess fluid out of your body.
Because wherever sodium goes, water naturally follows. That's just the basic rule of osmosis.
Precisely. But the problem arises precisely because of that upstream blockade.
Mm-hmm.
By stopping sodium absorption early in the tube, those standard diuretics send a massive sudden flood of sodium downstream to the very end of the line.
To the end of the tube.
Right. And that final segment of the plumbing is called the cortical collecting duct.
And I imagine the cortical collecting duct is not used to seeing a literal tsunami of sodium hit it all at once.
No, it completely panics.
Yeah.
The cells in that final collecting duct see this massive wave of valuable sodium about to be permanently lost in the urine, and the kidney frantically tries to claw it back.
Right, it wants to save the sodium.
But those specific cells operate on a very strict exchange system. They don't just pull sodium in for free. To pull one sodium ion back into the blood, they're forced to pump a potassium ion out into the urine.
Oh, wow. Which means by forcing all that sodium downstream, standard diuretics kind of back the kidney into a corner.
Exactly. The kidney saves the sodium, but in a panic, it pumps out all your potassium.
And that is the core mechanism of potassium wasting.
Yes. And that brings us directly to our main characters for today, the potassium-sparing diuretics. They step in at that very last segment, the cortical collecting duct, to halt that frantic exchange, keeping the potassium safely in the blood.
But wait, if I'm reading these notes right, they aren't just a single type of drug.
No, they're not.
We call them potassium-sparing diuretics, but they are actually two completely different biological tools that just happen to achieve the exact same end result.
Right, and to see why they are fundamentally different, we have to look at the raw numbers, what nephrologists often call the 2% rule.
The 2% rule?
Yeah. So the upstream plumbing, like the proximal tubule and the loop of Henle, they do all the heavy lifting. They handle about 90% of the sodium reabsorption.
Okay, 90%. That's huge.
The next segment handles another 5 to 8%. But the cortical collecting duct, where our potassium-sparing drugs actually operate, only handles about 2 to 3% of the filtered sodium.
Hold on, I'm getting stuck on the math here.
It's tricky.
If they only act on 2% of the sodium, how do they even do anything? I mean, that seems way too small to move a meaningful amount of water or make a difference in someone's blood pressure.
Your confusion is entirely justified, and it's the exact reason why, on their own, these drugs are fundamentally weak diuretics.
Ah.
They simply cannot move a lot of water because they don't have access to enough sodium. But it's how they act on that tiny 2% fraction that separates them into two totally distinct subfamilies.
Okay, break those two subfamilies down for us.
Sure. So the first subfamily is the aldosterone antagonists. This includes drugs like spironolactone and epithelial.
Spironolactone, right?
And what's crucial to understand is that their target isn't the sodium channel itself. Their target is actually a hormone called aldosterone.
Oh.
Under normal circumstances, aldosterone enters the principal cells of a collecting duct, travels to the nucleus, and literally commands the cell to build more sodium channels and more potassium pumps. Spironolactone and epithelial block the internal receptor for that hormone. They intercept the chemical message, shutting down the entire construction operation.
So they go straight to the source of the command, they stop it before it starts.
Exactly.
How does the second group work then?
The second subfamily is known as the epithelial sodium channel blockers, or ENAC blockers for short. This group includes drugs like amiloride and triamterene.
Amiloride and triamterene.
Yes, and these drugs do not interact with the hormone aldosterone at all. They operate completely independently of it.
Really?
Yeah. Instead of intercepting a chemical message, they physically plug the sodium pore on the luminal membrane, which is the actual surface of the cell facing the urine. They just block the drain directly.
Okay, let me try to visualize this. If the kidney is an exclusive nightclub, the aldosterone antagonists are essentially bribing the club manager, the hormone, to stop letting people in.
Right.
They go straight to management to change the policy. But the ENAC blockers are just shoving a giant wooden wedge under the front door. The manager can scream and yell all he wants from the office, but the door is physically barricaded.
That's actually a perfect analogy. One is a signaling blockade, and the other is a strict mechanical blockade.
But that raises a big question for me. Why on earth are they grouped together in the same drug class if they work so differently? It feels like we're categorizing a bribe and a doorstop as the exact same tool just because nobody got into the club.
What's fascinating here is that for decades, the medical community lumped them together in textbooks, purely because of that shared end result, keeping potassium in the blood.
So it was just based on the outcome.
Yeah, clinicians simply viewed them as two interchangeable flavors of a weak add-on drug. They were used purely to patch up the potassium leaks caused by those stronger upstream diuretics.
Wow.
But if we trace the actual history of how they were discovered, the illusion that they're the same thing completely shatters.
And to see that contrast, we have to travel back to the 1950s. The sources highlight two parallel, completely disconnected paths of drug discovery.
Very disconnected.
Let's start with the bribe, the manager drugs, the aldosterone antagonists.
The origin of those drugs starts in 1955 with an endocrinologist named Jerome Kahn at the University of Michigan.
Okay.
Kahn was studying a patient who presented with severe, unmanageable high blood pressure, extreme muscle weakness, and dangerously low potassium.
So the exact opposite of sparing.
Right. And through incredible detective work, Kahn discovered this patient had a tumor on their adrenal gland, and that tumor was autonomously pumping out massive toxic amounts of aldosterone.
Meaning the club manager was just constantly screaming to let more sodium in and kick all the potassium out.
Yes. Kahn named this condition primary hyperaldosteronism, which the medical world now calls Kahn's syndrome. And this singular discovery created a desperate, urgent need. Medicine suddenly needed a molecule that could specifically seek out and block aldosterone.
They needed a targeted weapon.
Exactly. Chemists at G.D. Searle and Company answered the call. They methodically custom-built a synthetic steroid compound, bringing spironolactone to the market by 1959.
Wow, 1959.
This was a rational, deliberately engineered receptor-targeted therapy decades before the phrase targeted therapy even existed in medicine.
It was a surgical strike against a very specific tumor hormone. That is amazing. But then you look at the other subfamily, the ENSC blockers, the drugs wedging the door shut, and their origin story isn't the surgical strike at all.
Not even close. While Searle was hunting for a specific hormone blocker, companies like Merck and SmithKline and French were just casting the widest net possible. They were running broad diuretic screening programs, testing thousands upon thousands of random chemicals in animals just to see what made them excrete more urine.
Just trial and error.
Total brute force. And in 1967, Merck discovered amiloride through this exact method. A few years earlier, SmithKline and French stumbled onto triamterene the same way.
So they weren't looking for a sophisticated aldosterone blocker at all.
No, they merely stumbled onto chemical structures that happened to physically plug the sodium channels and spare potassium. Pure fortunate accidents.
Wow.
They were only later grouped together with spironolactone because the clinical effect on a patient's potassium blood work looked identical.
Here's where it gets really interesting, though. You have one drug that was a deliberate surgical strike and other drugs that were lucky finds from mass chemical screening. But the sources show that the surgical strike drug, spironolactone, eventually broke out of this weak diuretic category and completely rewrote the rule book for how we treat heart failure.
It completely changed the game.
And I'm struggling to bridge that gap. If they only block 2% of sodium, how did a weak diuretic become a life-saving therapy? Did someone just decide to try it on very sick patients?
To bridge that gap, we have to look at a watershed moment in cardiology. The Rallies trial in 1999.
Okay, the Rallies trial.
It completely shattered the assumption that spironolactone was just a minor add-on. Researchers took over 1,600 patients suffering from severe heart failure. These were incredibly sick individuals already maxed out on standard heavy-duty therapies.
Right.
And the researchers decided to add just 25 milligrams of spironolactone to their daily regimen.
Just to put that into perspective for you listening, 25 milligrams is a microscopic dose for a diuretic. It's barely going to make a dent in a patient's fluid levels. You really wouldn't expect it to relieve their fluid buildup at all.
The clinical community expected very little, but the result sent shockwaves through medicine. Adding that tiny dose caused a 30% drop in overall mortality.
A 30% reduction in death.
The benefit was so profound and the data was so overwhelmingly clear that the independent safety monitors actually intervened and halted the trial early.
They stopped it.
Yes. They concluded it would be unethical to keep the placebo group off the drug for another day.
That is absolutely staggering. A 30% drop in mortality from a drug that isn't even doing the job it was originally named for. And the researchers didn't just stop there, did they?
No, they needed to prove it wasn't a fluke. A few years later, a trial called Ephesus used eplerenone for patients who had recently suffered heart attacks, showing a 15% drop in mortality.
Incredible.
Then in 2011, the Emphasis HF trial tested eplerenone on patients with only mild heart failure people, who doctors previously assumed were much too healthy to require this level of intervention.
And what happened?
It slashed cardiovascular death or hospitalization by 37%. Once again, they had to stop the trial early because it was saving too many lives.
It's the ultimate medical irony. A drug labeled as a diuretic is out there saving millions of lives when prescribed at a dose where it barely causes any diuresis. It clearly isn't saving them by making them pee.
Right.
So what is the actual mechanism? How is it keeping these hearts beating?
If we connect this to the bigger picture, the entire modern medical framing has shifted. We now understand that aldosterone does terrible destructive things to the cardiovascular system over a long period.
Like what?
High levels of aldosterone cause toxic fibrosis, which is structural scarring along with deep inflammation and negative remodeling of the heart tissue and blood vessels. Spironolactone and eplerenone are now primarily considered neurohormonal antagonists.
Neurohormonal antagonists.
Exactly. Their real job is to act as a shield, protecting the heart from the toxic effects of that hormone. The fact that they cause a tiny bit of diuresis and spare some potassium is practically just a historical footnote.
And it isn't just protecting the heart from failure either. The notes mention the Pathway 2 trial from 2015, which proved spironolactone is decisively the absolute best fourth-line drug for resistant hypertension.
Yes.
We're talking about patients whose high blood pressure won't budge even when they are taking 3 other heavy-duty medications.
Because it turns out a massive percentage of that stubborn, resistant high blood pressure is actually driven by undiagnosed, subtly elevated aldosterone levels in the background. Blocking the hormone neutralizes the hidden threat.
Okay, let me push back on something here.
Sure.
If spironolactone is this miracle drug, if it's this incredibly effective surgical strike against aldosterone that saves heart failure patients and fixes resistant hypertension, why did the pharmaceutical industry bother inventing eplerenone decades later? I mean, why spend the money to mess with perfection?
That brings us to a major misconception. The idea that spironolactone and eplerenone are perfectly clean, interchangeable drugs.
They're not.
No. Spironolactone's surgical strike actually had quite a bit of collateral damage. Remember, it was built in the 1950s using a synthetic steroid backbone. Because its physical shape looks so similar to other steroid hormones in the human body, it doesn't solely block aldosterone. It's a bit of a messy key that inadvertently fits into several other locks.
Messy in what way? What other locks is it turning?
Well, it accidentally blocks androgen receptors, the receptors for male sex hormones like testosterone, and it simultaneously activates progesterone receptors.
Oh, wow.
Clinically, this means that a substantial minority of men taking spironolactone develop gynecomastia, which is painful breast tissue enlargement. Women can also experience significant menstrual irregularities.
I see.
Eplerenone was engineered much later specifically to be a cleaner, highly selective molecule that only blocks aldosterone, bypassing those hormonal side effects, though it comes at the cost of being generally less potent and significantly more expensive.
But this is where pharmacology gets wild. A drug's major flaw in one clinical context suddenly becomes its superpower in another. Because of those exact anti-androgen properties, spironolactone has found this massive, unexpected audience completely off-label. It is widely prescribed by dermatologists to treat hormonal acne and hirsutism.
Right.
And it's a foundational treatment for polycystic ovary syndrome, or PCOS. Crucially, it has become a massive mainstay in feminizing hormone therapy for transgender women.
It's incredibly important.
The very side effect that caused distress for older male heart failure patients is the exact biological mechanism that makes it so vital for gender-affirming care.
It highlights how incredibly versatile these compounds are depending on the patient in front of you.
Yeah.
The patient populations just keep expanding.
Really?
Who else? For instance, in liver disease, specifically patients dealing with cirrhosis and abdominal fluid buildup called ascites and spironolactone remains the absolute first-line diuretic. Liver failure causes severe secondary hyperaldosteronism because the damaged liver stops clearing the hormone out of the blood.
Oh, so the hormone just builds up.
The hormone levels skyrocket, and spironolactone is exactly the shield needed to counter it.
The sheer volume of people taking this drug every day is breathtaking. You have heart failure patients, teenagers with acne, trans women, liver disease patients, and people with resistant hypertension.
It's a huge list.
But with a massive patient population comes a very real need to understand the risks. Because these drugs are used by so many different people for so many different reasons, we really need to highlight the red flags. What happens when things go wrong?
The absolute primary danger, the life-threatening complication every clinician monitors for, is hyperkalemia, having too much potassium in the blood.
Which makes sense. If you plug the potassium drain at the collecting duct and the patient keeps accumulating it, the levels are going to rise.
Right. Your body normally uses a complex chain reaction called the renin-angiotensin-aldosterone system, or RAAS, to manage blood pressure and potassium levels. Aldosterone is just the final step in that chain.
Okay.
The danger arises because many heart failure and blood pressure patients are also prescribed drugs called ACE inhibitors, or ARBs, which block that exact same chain reaction further upstream.
Wait, let me pause you there. ACE inhibitors I've heard of, but ARB, what does that acronym stand for?
ARB stands for angiotensin receptor blocker. Like ACE inhibitors, they reduce blood pressure by turning down the signals that eventually lead to aldosterone production.
Oh, I see.
If you layer a potassium-sparing diuretic on top of an ACE inhibitor or an ARB, you are aggressively blocking the body's potassium-wasting pathway at two completely different points. You are effectively stripping away the body's safety valves for getting rid of excess potassium.
So what does this all mean? Like, for the person listening, if their body is suddenly hoarding potassium because of these drug combinations, does their daily diet suddenly become a minefield? Like if they eat too many bananas?
Bananas rarely contain enough to be lethal, but you've hit on the exact clinical fear. The forces bring up a very specific, common, real-world scenario. Salt substitutes.
Salt substitutes.
Yeah. A lot of patients trying to actively manage their high blood pressure will buy salt substitutes at the grocery store to avoid sodium. But many of those substitutes achieve a salty flavor by using potassium chloride.
Oh, wow. So they are actively pouring potassium on their food.
Exactly. If a patient is taking spironolactone and an ACE inhibitor, their kidney literally cannot excrete potassium. If they then sprinkle potassium chloride all over their dinner, it can trigger severe, sometimes fatal, hyperkalemia.
That is terrifying.
Their potassium levels spike, which severely disrupts the electrical signals in the heart, leading to lethal arrhythmias.
It's a perfect storm of good intentions leading to a medical emergency.
Yes, it happens.
And what about the other drugs we talked about? The ENA-C blockers like triamterene. Do they have their own unique dangers?
Triamterene carries some very specific, underappreciated risks. For decades, the literature has documented cases where combining triamterene with Common over-the-counter NSAID painkillers like ibuprofen or prescription indomethacin causes sudden acute kidney injury.
Wow, just from taking an ibuprofen.
The NSAIDs alter blood flow to the kidney, interacting dangerously with the diuretic. Furthermore, triamterene and its broken-down metabolites have a unique tendency to crystallize in the urine. They can physically form kidney stones.
Oh, no one wants kidney stones.
It's a risk that is often overlooked, especially because triamterene is so casually prescribed in single combination pills alongside other diuretics.
Okay, to bring all of this science together, I want to tackle a concept from the notes that feels like the ultimate medical exam question. It's a scenario that perfectly proves everything we've unpacked today regarding how these two subfamilies are totally different. Can you explain Little syndrome?
Oh, Little syndrome is incredibly rare, but fascinating from a mechanical perspective. It is a genetic disease where a specific mutation causes the E-Nancy channel of the door at the nightclub to be permanently stuck wide open.
Just wedged open.
Yes, the cell is just constantly pulling in sodium and dumping out potassium, completely unregulated. Clinically, it leads to severe high blood pressure and dangerously low potassium, which perfectly mimics the symptoms of Conn syndrome, the adrenal tumor we discussed earlier.
But here's the trick, going back to our nightclub analogy. If the door is permanently wedged open by a genetic mutation, bribing the manager, giving them spironolactone to lower the hormone won't do anything, right? The hormone isn't the one keeping the door open.
This raises an important question about mechanics. Exactly. Spironolactone is entirely useless for a patient with Little syndrome.
Fascinating.
The aldosterone hormone levels are actually quite low in these patients because the body is naturally trying to shut the system down. The physical channel itself is the broken part. To treat Little syndrome, you must use amiloride or triamterene, the direct channel blockers, to physically plug that broken door.
That is so deeply satisfying to understand. It perfectly proves that the two subclasses are not interchangeable at all. Even though they both technically spare potassium, they are deployed to fix entirely different plumbing issues.
It's the ultimate proof of mechanism, and it demonstrates why understanding the exact microscopic pharmacology is so vital for patient care.
Let's synthesize this journey for you, the listener. We started with a drug class that, for decades, was casually dismissed as just a weak, boring add-on used to keep potassium levels stable, while stronger drugs did the actual heavy lifting.
Good.
But peeling back the layers, we discovered a class containing two completely distinct mechanisms, one that mechanically plugs a cellular channel and one that boldly intercepts a powerful hormone.
And by eventually understanding the true nuance of that tiny 2 to 3% sodium segment, medical science unlocked a way to halt the toxic structural remodeling effects of aldosterone. That realization has saved countless lives in heart failure, transforming cardiovascular medicine from the ground up.
While accidentally providing vital, life-changing therapies for dermatology and transgender care along the way, it is a wild, unpredictable ride. And I want to leave you with something to chew on as you go about your day. Think about how spironolactone's life-saving heart failure properties and its massive anti-androgen effects were discovered decades after it was put on the market as a simple water pill.
Decades later.
It really makes you wonder, how many other older, seemingly boring medications currently sitting quietly in our pharmacy aisles are hiding entirely different revolutionary capabilities just waiting for us to look past their original labels? Next time you look at a prescription bottle, remember the straight line might just be an illusion. Thank you so much for joining us on this deep dive. We'll catch you next time.